Dr. Tsai, at the Glaucoma 360 meeting, you presented a talk on aqueous misdirection syndrome with pitfalls and pearls. Could you sort of give an overview of your talk?
Yes, I wanted to give the clinician an idea of a type of glaucoma which oftentimes occurs in patients with angle closure or narrow angle glaucoma when glaucoma filtering surgery is performed. This type of glaucoma can be very difficult to manage, and patients can present with either normal or elevated intraocular pressures. The important thing to realize is that patients have very shallow anterior chambers, including in the periphery and also centrally. So this is an important type of glaucoma to diagnose.
How prevalent is it?
It's not very common. It's about 1 to 4% of all glaucoma surgeries may face this. But when it occurs, patients can be very difficult to manage. It's important to understand that one can treat it first medically before intervening surgically if necessary.
And what's your recommended approach when they come across this?
My recommended approach is first to diagnose the type of glaucoma. Malignant or aqueous misdirection or ciliary block glaucoma. What we think happens in this type of glaucoma is that aqueous is diverted back posteriorly into the midvitreous or posterior vitreous. There seems to be an abnormal rotation of the ciliary body processes. In these cases, one first has to make sure that it is in fact malignant glaucoma. You ideally want to have the patient have a peripheral iridectomy. So this is a type of angle closure glaucoma when you have a patent iridectomy or iridotomy.
And final question, what's the take-home message for the clinician?
Well, the take-home message for the clinician is you can diagnose this with ultrasound biomicroscopy, UBM, or ultrasound. You can treat it first initially with topical atropine eye drops and maybe some steroids. And if that doesn't work, to intervene surgically, either laser therapy or even the need for posterior pars plana vitrectomy.
Thank you, Dr. Tsai. I appreciate your time.